feel supported, and then probably like, all right, here we go. Well, I would like to welcome everyone on this call and on this virtual conference today. I'm extremely excited to see such a large and awesome group. For those of you who do not know me, my name is Tyler Tate, and I am a pediatric palliative care physician and one of the associate directors here at the OHSU Center for Ethics in Healthcare, where I get to have the pleasure of working
Charlie,
with
did
our
you sign up
speaker
for this
today.
thing? Cool. And then
And
after
we
the meeting,
all,
can I use your computer?
there's a lot of noise. If everyone could please mute themselves, and if not, Dave, if you could take control of that as well, that would be awesome. Thank you. So today, I have the honor and pleasure of introducing someone who I get to work with on a daily basis, which is very exciting. But before we get to further introductions, I do want to welcome everyone. Today, what you're going to hear is part of a lecture series presentation that is called Trust in the Ruins. And today, Dr. Susan Tolle will be speaking about Advance Directives. Are we expecting more than they can deliver? Apropos, I want to mention to everyone, please mute yourselves. As much as we enjoy hearing all varieties of conversations, today will be focused on Dr. Tolle. Please remember that in order to receive continuing education credit, you need to sign in via the link in the chat and complete the evaluation at the link, which will be provided at the end. I also want to mention that we have a new program manager, Dave Hoyt, who's working with us as part of our Center for Ethics and Healthcare team. Super excited to welcome him today for his first series managing with me. It's been really fantastic to work with him so far. So from February to June 2022, Oregon Health and Science University Centers for Ethics and Healthcare presents this virtual lecture series, Trust in the Ruins. In the wake of a global pandemic, can we reimagine health and rebuild trust in the field and practice of medicine? In this 5-part lecture series, experts from a variety of disciplines have been discussing the important concept of trust. What is trust and why is it important for healthcare? In American medicine today, mistrust abounds. Why is this the case? And what can medical practitioners and health systems do to establish trust afresh? Our excellent guest speakers will offer historical perspectives on trust, mistrust, medicine, and will provide strategies for cultivating trustworthy patient-clinician relationships and trustworthy systems of care in Oregon and beyond. And today, Dr. Tolle will be talking about advanced care planning and advanced directives, which, as many of you on this call know, is sort of a real location where trust and mistrust have abounded, and there are so many opportunities for further discussion about how these important concepts engage with each other. So it's my pleasure to introduce our speaker for today. My boss, Dr. Susan Tolle. Dr. Tolle is a graduate of Oregon Health and Science University School of Medicine. After graduating AOA from OHSU, she completed her internal medicine residency at UC San Diego, where she was also chief resident. She later completed a fellowship in clinical medical ethics at the University of Chicago. Dr. Tolle founded and has directed the Oregon Health and Science University Center for Ethics in Healthcare since 1989 and has shepherded its growth into a now internationally recognized ethics center with programs such as the Portable Orders for Life-Sustaining Treatment, or POLST program, and more recently, the Program in Compassionate Communication. Dr. Tolle is a professor of medicine and holds the Cornelia Hayes Stevens Endowed Chair in Healthcare Ethics. Her awards include the 2014 McLean Prize in Clinical Medical Ethics and the OHSU 2016 Esther Pohl Lovejoy Leadership Alumni Award. She also serves as the chair of the Oregon POLST Coalition. So, Dr. Tolle, we look forward to your talk. I will be moderating the talk. During Dr. Tolle's talk, feel free to turn off your camera. Please mute yourself. And then when we return after her talk, we will have a robust question and answer session, which I will moderate. And at that point, we can unmute ourselves if we would like to speak or turn on our cameras. Thank you, Dr. Tolle.
Well, thank you everyone for coming. I thought on spring break we would have a more modest turnout. But the talk is timely and challenging. And so many of you are more expert than I am in some aspects about advance directives. But we have seen some recent literature that's made all of us ask questions about whether we're expecting more than they can deliver. And so we'll spend some time looking at that question. I do not have, nor does the Center for Ethics have any conflict of interest to disclose. We do not accept gifts from healthcare industry sources. And that's particularly relevant related to the POLST program. If more POLST forms are ordered or completed one way or another, it does not financially benefit the Center for Ethics. We have actually 4 objectives: to examine the way advance directives are effective, what they actually do accomplish, to look at data about shortcomings of advance directives, to explore challenges to assure that people with disabilities are receiving appropriate care, not more and not less than they would have wanted. And finally, a 4th, not on the list, of looking at some things we can do to be more effective in what achieves patient concordant goals. One of the biggest challenges is to explain the difference between advance directives and POLST to a lay audience. People find the 2 documents and either document alone often confusing. This was created by the Next Door to try to explain in much more clear health literacy attended to language the difference between advance directives and POLST. The biggest differences include, as we all know, that POLST is for people with serious illness, for those with a more limited life expectancy with a diagnosis that is clear, or they have advanced frailty. POLST is a medical order. And one of the challenges with advance directives is that they are often completed as part of an estate planning process with an attorney, but there may not be communication to assure that the advance directive even is ever entered in the medical record, or that detailed conversations occur. So those are among some of the challenges. But let's start with the good news. Let's start with, in what ways are advanced directives effective? What things do they actually do that research studies over time have confirmed that they make a difference, that they accomplish a goal that they were set out to do? And there are 2 very big ways that they do make a difference. One is about stress. On families, particularly, measures of stress. This is a study that Virginia Tilden, I, and colleagues did in the late 1990s, interviewing family members who had participated in a decision to withdraw life-sustaining treatment in one of the greater Portland hospitals. We used an instrument called the Horowitz. It measures stress after things like a disaster, like having your home burned in a fire, how often you have intrusive thoughts, how much doubt you have about whether you should have done something differently. And a higher number means more stress. So what we see is that if there was a written advance directive, and perhaps also conversations, we hope, stress levels were substantially lower than if there was some sort of verbal communication, though perhaps not in depth, versus neither. Nothing written, nothing said to guide people. The amount of waking up at 2 a.m. and going, I wonder if I did the right thing, occurred so much more often. And we were very struck by the kinds of quotes that families had. Things like, I wouldn't wish making this decision on my worst enemy. So these are very stressful things for families, and advanced care planning in a much more recent study published in the Journal of the American Geriatric Society reviewed literature in great detail and looked at what is the impact and what happens. And study after study has confirmed that there is reduced anxiety, reduced intensity of grief, less post-traumatic stress, and less burden overall on surrogate decision makers. That there is an emotional impact that has been well substantiated to make a difference. Now, this is advanced care planning. This doesn't necessarily mean you filled out an advance directive. Every I was dotted, every T was crossed, but conversations did not occur. This is likely associated with real conversations about goals of care and family conversations that help all of this happen and help the person make plans and prepare. The second very powerful thing that advance directives do is they allow you to appoint a surrogate. The surrogate's name may be different in different states, healthcare representative, power of attorney for healthcare, but this is a person who can make decisions for you if you can't make decisions for yourself. And hopefully there have been in-depth conversations with the person appointed about your philosophy, your goals, and that gives the peace of mind and sense of direction and reduced distress that was outlined in the earlier slide. POLST is not a way to appoint a surrogate. It is a way for a surrogate to move from an advance directive to orders regarding life-sustaining treatment in someone who has lost capacity. We'll now transition to the shortcomings of advance directives. I share this scene because the data, this is about the pieces of paper, the advance directive. This is not about thoughtful conversations. This is about the advance directives themselves and what they've been associated with. They don't change the frequency of this scene. A lot of attention focused on the issue of advance directives and whether or not the trust that people place that their wishes will be honored is actually true in real life. Sean Morrison wrote this piece in the Journal of Palliative Medicine, Advance Directives, Care Planning, Clear, Simple, and Wrong, 2 years ago. It generated a great deal of controversy. It was based on this and his clinical experience as a palliative care leader. A review that looked at over 1,600 articles and about advance directives. Much has been written about advance directives. Some of them are, how do you get people to complete more advance directives? How are they marked? Lots of different studies. They found 80 that were about outcome and concordance of care in this systematic review. And the overall conclusions were that there was no evidence of influence on actual medical decisions that were made and no association with goal concordance. Now, one of the challenges is that many advance directives, including Oregon, have specific scenarios that one responds to. If I am in permanent coma, if I can no longer recognize friends or family. But they're filled out when that is not, when it's theoretical, when the patient is not thought to be on that trajectory, and they're thinking about the future. And we'll talk a little bit about why theorizing with scenarios that are not related to a disease you have at the present time may bring in the bias that society has about disability, both healthcare professionals, but in this case, the patients themselves. And that as they begin to have some limitations, they often find that life is much higher quality than they had thought it would be, looking way into the future. Another article written slightly more recently in the Journal of the American Geriatric Society looked at 62 high-quality articles and is part of the outstanding documentation about the benefits regarding depression, stress, grief, burden on families, but also concurred that there was no evidence of influence on goal concordant care of advance directives, and there was no association with emergency department visits, hospitalization, or critical care. Now, that does not mean that when someone has an active condition, advanced cancer, for example, and there are in-depth conversations with palliative care or others that that they might not enroll in hospice sooner, et cetera. This is about advanced care planning documents. Here's another study that helps say some of the same things. That this is by Maria Silveira and colleagues. And it looked at an ongoing study, the health and retirement study, and looked at people over age 60. At the time of death, did they have an advance directive? And how, over a number of years, have the number of advance directives changed? And was there any association between hospitalizations and death in the hospital and having advance directives? And during the time of the study, the amount of advance directives approximately doubled, and there was no association between hospitalizations and death with having completed an advance directive. Pieces of paper alone don't get you what you want, is a take-home message. That simply filling out documents, including filling them out perfectly, will not help avoid a death in the hospital if that is your goal. There are probably several reasons for that, including the need for in-depth conversation with surrogates to help effectuate things when one loses capacity near the end of life. But another is saying no to things is not a plan of care. Saying, I don't want to go to the hospital, I want to die in my own bed, will not make that happen. There needs to be a whole plan of care for what does happen and systems in place to support making it happen. And we'll talk further about what those systems look like and why Oregon looks different than some other parts of the country. One of the things Sean Morrison highlighted is the issue of money. Where you die and what your zip code is are substantially important and tragically more strongly associated with your zip code than your preference. These are from the Dartmouth Atlas, and I'll show two figures that help us see how important the role of healthcare financing is. This is Medicare reimbursement data from 2018. It looks at hospital referral regions, which is the standard way to divide up. Oregon has 5. And it looks at how much per year in reimbursements per referral region are paid per Medicare enrollee. Oregon, as you can see, is in the lightest green, the bottom tier, the least payments for Medicare enrollee group, with some parts of the country nearly twice as much per Medicare enrollee. And you can see that involves Southern California, lots of the South, including Texas and Florida, and that the Northwest is reimbursed at a low level and has, in general, fewer hospital beds per 1,000 population. This overlays hospitalizations, days in the hospital per chronically ill Medicare enrollee in the final 6 months of life. So people who would be hospice eligible and are in their last 6 months of life, looking back from the time they died, how many days on average are they in the hospital? As you can see, all but one catchment region of Oregon is in the lowest tier for days in the hospital, and that parts of the country are threefold higher. And they include the areas we saw previously on the map, though New York lights up a little bit more than the prior map. But the overlay of time in the hospital near the end of life and how much you're paid per Medicare enrollee and the beds per 1,000 do influence the amount of time and the rate of death in the hospital. Let's look a little bit at Oregon and how we compare with the rest of the country. And look at 4 different variables. This is fee-for-service Medicare. It's an article that I wrote with Joan Tino in the New England Journal of Medicine in 2017. We looked at several periods of time. Oregon is blue, Washington is shades of orange, and the rest of the country is yellow. And this is died at home. The definition of home is it's not a nursing home, it's not an acute care hospital, and it's not an inpatient hospice bed. So if you lived in an adult foster care, that would be your home. If you lived in assisted living, that would be your home. Private home would be your home. And as you can see, Oregon is much higher than Washington and the rest of the country. This is about if you were admitted to the hospital in the last 30 days of life, what were the odds that you were discharged and went home? And as you can see, Oregon is still higher for specifically that if you came into the hospital being discharged to home rather than, for example, a nursing home. The percentage of fee-for-service Medicare enrollees enrolled in hospice in Oregon has been high relative to the rest of the country, and this is for in-home hospice, which also includes the broader term for home. And last, the percentage of fee-for-service Medicare beneficiaries who received care in the ICU in the last 30 days of life. And Oregon is much lower than Washington and the rest of the country, but slowly rising. So the fact that we have fewer beds and that we have more alternatives like assisted living and adult foster care may influence some of this decision making, but we certainly have strong incentives in Oregon to both honor patient wishes, but perhaps limit hospitalizations. And when we think of the balance of doing what someone wants and the financial forces, Oregon may be slightly more at risk to encourage people to be at home and cared for by family, even if that burden may be very great, and even if perhaps there's a struggle to manage suffering at home, we would be at risk on the other end of the spectrum, where places with the highest rates of in-hospital death would be at risk of hospitalizing you when you could have been cared for at home had you lived in Oregon or other states that have higher rates of death at home. I'd like to spend a minute on this: advanced care planning and people with disabilities. The overall goal of this talk is not to promote more POLST use, or it is to promote the wise and respectful honoring of what people want as they near the end of their lives. But it's also to prevent bias and the overuse or misuse of advanced care planning and POLST. And people with disabilities may face some additional biases that require increased attention, and they may require additional support in being able to articulate their goals and have them honored. We need to guard against bias in the care of people with disabilities, including the potential bias of people themselves being biased against their own disabilities in the future, only to find them more acceptable once they have some limitations of advanced age. Recent studies, this one's from a year ago, surveying attitudes about the perception of quality of life of people with disabilities and their healthcare professionals. So it showed that 82% of physicians reported that people with significant disabilities had a lower quality of life than non-disabled people. But in a similar survey of people with disabilities, quality of life was rated much higher by the people themselves. So there's a clear indication that we need to be vigilant about bias in people with disabilities. The Oregon POLST Coalition has worked very closely with the Oregon Health Authority and DHS to write a guidebook that focuses on both sides of this equation. We are aware that there are people with disabilities who do not get high quality end of life care that most other Oregonians get. That as they decline and are nearing the end of life, which may be completely unrelated to their disability, that they may have advanced cancer or advanced lung disease or advanced heart disease, and that they may not be enrolled in hospice as soon. And in one study, it suggested they get CPR in the hospital significantly more often than those without, in that case, intellectual disabilities. We are aware that in the past, some group homes have required that even if a patient was in hospice, that they receive CPR until EMS arrived, even if they had a POLST form with do not resuscitate orders. So that's the side where we're saying everyone deserves access to high quality end of life care. But we are also aware of the need for vigilance to assure that POLST is not completed in people with disabilities who are stable and have a long lifespan ahead. And this document, which is available on the Oregon POLST website, explores both issues in some detail and helps understand how we reduce and prevent bias and how we integrate with the expectations of Senate Bill 1606. Shifting gears. Who is POLST for? It is not for healthy people. It is for people with serious illness, who are very old and frail, who want to set limits in the present. You don't need a POLST form if you want full code, full treatment. That's the default. That will happen anyway. That's what EMS does by protocol. So POLST is most useful for people who qualify, who are nearing the end of their lives, and who want to set limits. They have advanced cancer, for example, that has spread, and they've made a decision not to pursue additional treatment. They have advanced heart disease, and maybe they don't want to go to the intensive care unit again. They have advanced dementia. They're getting aspiration pneumonia. They are nearing the end of their lives. They've already completed an advance directive, and their surrogate may wish to complete a POLST form, honoring their wishes. They have advanced frailty. A number of organ systems are not at full speed, but one is not out there a lot farther than all the others. But they may wish to set some limits. In fact, those in assisted living, the most common way a POLST form is marked is do not resuscitate and limited treatment. I want to go back to the hospital. I want the basic things fixed. But I don't want intensive care and I don't want life support. Let's look at how often POLST is used in Oregon because it's pretty remarkable. This is a study led by Dana Zive. I was the senior author, and it matched POLST forms in the registry in 2015 and 2016, looking at whether or not the patient had a POLST form and looking at what were the causes of death. Now, not everybody's POLST form gets into the registry, but actually entered was nearly half. So we believe that over half of Oregonians actually have a POLST form at the time of death. And we only match death certificates in Oregon. So if you died in Vancouver or whatever, we wouldn't have been able to identify it. you can see that there are some pretty substantial differences in POLST completion by cause of death. That if someone has Alzheimer's or Parkinson's, about 2/3 of the time, they will have a POLST form completed at the time of death. And if it's cancer, it's about half of the time. So trajectory to death matters related to the degree of planning and planning to write medical orders. And who likely has had more opportunities for conversations, because slower trajectories to death, like Parkinson's and Alzheimer's, certainly provide a lot more time for goals of care conversations and a more obvious slow decline. POLST at the time of death, from that, from a look at a 2-cohort study, we looked at whether or not someone had a POLST form at the time of death and what it said. So the orange is that they wanted CPR. The blue is whether they had orders for do not resuscitate, and we have much more careful groupings about other orders as well, because we all know that do not resuscitate does not mean do not treat. And we also know that a very common way that POLST is marked is do not resuscitate and limited interventions, though the majority of people at the time of death have do not resuscitate and comfort measures only, and have changed their POLST form if it was limited to set further limits near the time of death. But look at the age groups. POLST is extremely heavily used by those in advanced age. That most people who die, the median is 81 and older, the majority have a POLST form at the time of death. So POLST is heavily used by frail elders and those with advanced heart disease, lung disease, cancer, who also often are in more advanced years. There are about 35 people a year who die under age 18 with a POLST form. Is POLST associated with greater concordance? Do you, if you say you do not wish to die in the hospital, do you have a lower rate of death in the hospital? We use the word associated for an important reason. There have never been any randomized controlled trials of POLST. And who completes a POLST for comfort measures is a very different kind of person, perhaps, than who completes a POLST for full treatment, even if they have the same level measurable of advanced comorbidities and disease. So in this study, we looked at deaths in 2010 and 2011. Eric Fromey is the first author. I'm the senior author. This was published in JAGS. And what we found was, looking at death certificates, if someone had comfort measures only and do not resuscitate, they had a 6.4% chance of dying in the hospital. The number went up substantially if it was limited treatment, but you had wanted to go back to the hospital. So obviously the odds of dying there would be greater. If you had a POLST form for full treatment, your chance was profoundly higher of dying in the hospital. And while this says no POLST in the registry, I do want to emphasize it's no POLST in the registry. It doesn't mean they didn't have a POLST form. The registry was new at this time, and some people's forms were not in the registry had been completed before it became operational. So full treatment and no POLST may be a little bit of a mix of the fact that no POLST had some POLST forms in it. We just didn't have them in the registry. But people really paid attention to this incredibly low number of in-hospital deaths because it meant that people were calling 911 less often, in people with comfort measures only, enrolling in hospice and calling hospice more often, and finding other means to stay at home. Now, is POLST the explanation? So many people have looked at Oregon's data across the country and said, let's build a registry, let's push out a POLST program, let's get data that looks like Oregon, often with an eye toward cost savings. Because in general, dying at home is less expensive than dying in the hospital. The answer is no. Putting pieces of paper, no matter how good they are or how clear they are, or even with the ability to find them, will not get you what you want. It is not a plan of care. And it does not mean thoughtful conversations have taken place with surrogates who will be asked questions if you're no longer capable. So alone, a POLST form does not explain Oregon data, is my deep belief. We have more concordance with a POLST form and location of death than you see with advance directives and location of death. That's very clear. But it takes more than a POLST form. And when people look at Oregon and what we've accomplished, it's so important to realize all the other things that are here on which the POLST program can be successful. But to me, the POLST is the last part of the advanced care planning, not the front end. For example, we have very nimble hospice response, a little more challenging during the pandemic as there have been some staffing issues, but historically much more nimble than much of the rest of the country in enrolling people quickly rather than having them be admitted to be enrolled. There are more options in Oregon than many other states for community-based care. Not community-based care for inpatient hospice. We are low on that. But for adult foster care and assisted living, we are leaders and have more options than most other states. We also have outstanding systems for locating existing POLST forms. And the statewide registry has been in place now for 12 years and is widely used and has had over 16,000 calls in a crisis to the Emergency Communications Center, is identified in most healthcare systems on the patient toolbar. Some health systems have bidirectional communication with the registry, and we hope more will over time. But systems of actually finding POLST forms and recording them in ways they can be identified, replaced, updated, are key to the fact that a piece of paper actually means something. Now, we are not perfect. We may be exemplars compared to many other states related to POLST, but we have ongoing challenges. One of our bigger challenges is do not resuscitate limited treatment. You saw that huge jump between death in hospital if it said limited treatment. and comfort measures only. So you needed an IV for a serious infection. You needed inpatient care. You wanted that, but you didn't want intensive care. And once people are in the hospital, being sure that our health systems remember the plan of care is still a bit of a challenge. It takes so much more than documents to have goal concordant care. There are many amazing programs that help with thoughtful conversations between the surrogate and the patient, and perhaps the rest of the family. They're outstanding, and Oregon uses many of them to teach healthcare professionals how to better have goal concordant care. We have training in Vital Talk and in respecting choices and in serious illness communication via Ariadne Labs. We have encouragement to use the wonderful Prepare for Your Care documents, the Volandes videos, tools to help promote conversations, and we've made a number of them for the POLST program as well for the lay public, and are moving into more with other languages. We've had Spanish for over a decade. But this part is under-attended to in the POLST completion process, in the advanced care planning process, in the advanced directive process. And it's about much more than the document. It's about a true plan of care for what you want and how to make it happen. And the how to make it happen is often left off the table as people in their enthusiasm promote documents. It's my belief that together we can become more trustworthy care partners, and that the promise of these documents can be more often honored in truly goal concordant care. So I welcome questions. I'll need Tyler's help with the chat. It looks like it's been lively. And welcome your thoughts and your expertise. And I see that Rich Malarski has his hand up. Perhaps we'll start with you, Rich, and then Tyler can help out with what might be in the chat.
Well, fantastic talk, Susan. Thanks so much for bringing this to all of us today. I wanted to bring up a couple of issues that I think often don't enter the conversation as much. And you've touched on them a lot, that the POLST comes at the end of the journey or later in the journey, that it is a journey, that it's challenging to talk about these issues. But the two things that, as many of you know, I moved to Oregon in the mid-90s, primarily to be part of the discussions around physician-assisted suicide and the ethics that you were just starting at the time. I think the POLST committee started in 92, 94, something like that, around these issues, recognizing that they were so important to me as an ICU provider in the work that I do. And some of the things we don't talk about is that it's impossible to know what you know until you, shout out to Eric Fromme in a Buddhist way, until you know. And what I mean by that is, Molly Osborne and I in the late 90s slipped this word into some of our publications. It's the pacing of, both patients and their families, but it's especially apparent in the ICU when that decision-making gets truncated often to days as opposed to, more preferably weeks, months, and years. And I don't think we talk about that enough. Vital Talk helps us to respond to emotions, deal with anticipatory and real grief, but still doesn't help us help patients experience things. The Volanda videos are a wonderful way to start to get at that. And so my question is, let's not throw the baby out with the bathwater. When I moved from Oregon to, shall we say, a highly revered Southern California healthcare institution that at the time had the highest rate of ICU at the end of life from the Dartmouth Atlas. It was very different, because we had a community dialogue about physician-assisted suicide in Oregon. People were used to talking about these things. I think the death cafe movement hasn't caught on because nobody wants to talk about death. But when we ask patients to tell us their preferences, most shrug their shoulders. And so unless we figure out how to do this iteratively, similar to maybe what Jen Temmel, demonstrated over a decade ago with lung cancer, if you have concurrent management with palliative care, those issues can get integrated. Although even there, we haven't been able to measure, the intangible things. The study that you and Virginia and Susan did, showing that there was less stress, I think gets at that intangible benefit. It allows people to start this pacing, to start to explore, what do I want? What are my options? What does it look like to be in the ICU? Maybe I want to try that first before I say no. Well, you might try that first and a quarter of you are going to end up dying in my ICU. What are your thoughts, Susan? Thank you for letting me be a little bit wandering there.
Well, thank you so much. I think you said it all so well, the degree of complexity, the importance of having documents after conversations, and I would add the importance of conversations over time coming from a primary care perspective, and the fact that people do change their mind. Tyler, can you help us out in shouting out a few other things that are in the chat?
Indeed. Much of the conversation has been just not direct questions, but David Clark has asked, are there any studies that break down POLST or end-of-life care by race, ethnicity, and religion?
Yes, there are. Oregon has an interesting population curve. And when we look at diversity, we have a lot more diversity in the grade schools than we have in people of advanced age. So in most of our studies, there were only about 6% of people with color, because that's the percent on Oregon death certificates. And so making comparisons, we did find that there are slightly lower rates of POLST completion in persons with lower levels of education. And there are slightly lower levels of completion of POLST, but again, we start to get into smaller numbers of persons who are Latinx or who are Black. Now, Maryland requires POLST form completion in certain care settings like nursing homes. And so they have looked at race and have more racial diversity in their older population than we do. And the percent of people who want full code, full treatment, who are Black is very different than the way we showed you how POLST is marked in Oregon. And 2/3 want full code, full treatment. So how POLST are completed and when and if they are does vary by race and education level.
Thank you, Susan. Harry Krulich, would you like to unmute and ask your question? I want to make sure, I'm not sure I would do it justice.
Sure. Most of you know I've been doing community-based geriatrics since 1993. And my experience is that regardless of the ownership, size, structure, or location, the pressure on the frontline staff to send every patient with a DNR limited to the hospital is driven by management specific instructions that their jobs could actually be at risk if they don't get those people out of there unless they're on comfort care because of liability. And because we do have such a strong educational program, starting at PACE, when I worked with Dr. Brummelsmith, the physicians tried to initiate comfort care when we felt that the patients needed to be moved up to that category and not wait for any family to bring that issue to our attention, because we found that we had too many patients getting hospitalized. After I left Elder Place in 2010, it's still in 2000, for the last 20 years, that's still been my experience in private practice. And that comfort care, like Dr. Lynn found out in the support study, may be an anthropological marker that those of us with palliative and geriatric training feel that it's ready for the patient to be dying at home. And we're initiating those decisions, and it's not necessarily in concordance with the family or the patient's wishes, but we're bringing it up because we can't keep the person at limited, or they will be hospitalized wherever they live.
Well, there's certainly incentives to hospitalize people in some contexts, and who benefits and who economically benefits. And we do have the most challenge with the category limited treatment, because you do want to go back to the hospital. Dr. Tate, I think we're nearing the end of our hour, and you may have another announcement or two, so I'm going to turn it back to you.
Thanks, Susan. I guess, yes. We have 3 minutes, and while I gather that announcement, is there any sort of last concluding remark that you would want to make, sort of as a summary statement of just this excellent talk, the things that you really are hoping to sort of see in the next, upcoming years?
We do need to use clearer language than we've ever used before in communicating with the public. That all of us need to find ways to make what we are describing easier to understand. And it is a major initiative for the POLST program, with translation of the POLST form into 15 languages, and then the goal to work with community health workers to go out in community and actually see if the lay materials are understandable and culturally respectful. So I think there's still plenty of work to be done in so many different ways, but we are faced with the challenge of DNR limited and whether or not it will remain limited.
Thanks, Susan. And thank you, everyone, for your rich conversations and discussions here. Dave Hoyt, if you wouldn't mind, before this chat closes, just copying all of the comments into a document and then sending it to Dr. Tolle so that she could perhaps respond individually via email for other conversations afterward. So 2 quick comments. First, I want to mention that we have coming soon is the 2022 Kinsman Annual Bioethics Conference, which we will be putting on, we being the OHSU Center for Ethics in Healthcare. This year's title is Ethical Struggles During the Pandemic, Reflections and a Path Forward. It'll be virtual via WebEx, April 28th through 29th, 2002. That's April 28th through 29th, 2002. Dave Hoyt has just put the information into the chat. We have a great group of speakers, and I'm really looking forward to this conference. And last but not least, we have several more exciting speakers coming up in this speaker series, Trust in the Ruins. Next, we will have Maya Mickelson, who's will be speaking on Friday, April 22nd at 8 a.m. Her presentation will be titled Trust in the Limits, Creating Trust and Meaning in the Space where the patient ends and the clinician begins. Maya is a pediatric palliative care chaplain, and I will get to work with her here at OHSU, and is just an incredibly sensitive and thoughtful voice, and I really look forward to her upcoming talk. So that's all we have today. Thank you all for joining us. Thank you, Dr. Tolle, for your rich and enlightening talk, and we know that this will just be the beginning of many more conversations, and we thank you for all your many years of work on this important area.
Thank you so very much. I learned so much from all of you.
Thank you.
Take care, everyone.
Together, we're making a difference. And don't forget to